Hello everyone and welcome to this session of instruments. Here I'm going to briefly describe some of the instruments that we commonly use in ENT and that is necessary for your examination. We will not discuss into detail, but the thing here to identify is when you're given an MCQ on instrument, you should be able to at least recognize it, which is when you'll understand the applications. So the aim of this chapter is going to be understanding the instrument and what is the application of this instrument in ENT or where is it used in ENT. So without wasting any time, let's go ahead. So the first instrument that you see here is called as the Jobson horn probe with a ring curette. So if you see, this is like a probe, like a simple probe, but you see on one end there is a ring, on the other end you see a serrated edge. So you have a probe which is having two ends. One end is like a ring and the other one is a serrated edge. Why do we use this instrument? This instrument typically is used for many purposes. First and foremost, it is used for removal of wax. It is used for removal of foreign body. It is also used to remove some of the granulations if they are present in the external auditory canal. Now, if there is a polyp, it is used to probe the polyp to understand from where it is originating. So for probing, you will use the serrated end, but for removal of wax, you are going to use the ring curette end. So the name of this instrument is Jobson horn probe with a ring curette. Now let us see the second instrument which we commonly use in every ENT OPD is this tuning fork, which is called as the Hartmann's tuning fork. There are different types of tuning fork and we get it in different frequencies as well. So we have 256 Hz, we have 512 Hz, we have 1024 Hz, which we commonly use in a OPD. So we have Rinne's test, Weber's test, absolute bone conduction test, which we do with this tuning fork and get our inferences to understand if there is a conductive hearing loss or a sensory neural hearing loss. And then we subject the patient to further tests in terms of audiometry or any special tests if required. So for basic essential to understand if there is any hearing loss, you're going to do this tuning fork test with commonly used forks, which is 256, 512 and 1024. Now you can see this is called as the Siegel's pneumatic speculum. So you have an oral speculum. To this oral speculum, you have a pneumatic attachment that is present. So there is a pneumatic attachment to a oral speculum. So this oral speculum is inserted into the external auditory canal of the patient. And here we have the Siegel's pneumatic attachment that is attached to the oral speculum. From the outside, we can see what is happening to the tympanic membrane. So whenever we want to increase the pressure, we will inflate the cuff, the pressure in the canal will increase. When we deflate the cuff, the pressure in the canal will decrease. So on increasing and decreasing the pressure, we will test the mobility of the tympanic membrane. We can also do a test which is called as the fistula test. So the use of this oral speculum with a pneumatic attachment is not just for doing Siegelization or visualizing the movement of tympanic membrane. It is also used to perform a test which is called as the fistula test. So it is used for fistula test and also for movement of the tympanic membrane. So this is called as the Siegel's pneumatic speculum. Now we have otoscope with a pneumatic attachment as well. So otoscope is an instrument which is inserted into the external auditory canal, but does it give us only direct view of the tympanic membrane or a magnified view? It will give us a magnified view of the tympanic membrane. So it gives us about 2x magnification or 2.5x magnification. So we will be able to understand the pathologies in the external auditory canal and the tympanic membrane better. We will be able to understand the retraction, perforation, any discharge, granulation, and understand it because it's giving us a magnified view. So this is the otoscope. To otoscope, we can again have a pneumatic attachment to visualize the movement of the tympanic membrane and also to perform the fistula test, just like what we saw in the prior slide. So they are used not just to see tympanic membrane mobility, but also used for performing the fistula test. So this is about your otoscope. Now we have this syringe which is called as the Simpson's oral syringe, where you have a cylindrical body, and in this cylindrical body you have a nozzle. So this is typically used for performing an ear wash. So whenever you do a ear wash or whenever you do a procedure which we call it as syringing, we take the water into this Simpson's oral syringe. This water has to be of the body temperature. Body temperature means 37 degrees centigrade. If you use warm water or cold water, the thermal currents can stimulate the labyrinth to cause vertigo and nystagmus, causing a caloric reaction. So you will use body temperature water. It is used for syringing. It is used for removal of foreign body, and it is used for removal of wax. We don't use it for a hygroscopic foreign body or an organic foreign body, because with water the hygroscopic foreign body or the organic foreign body can swell, causing further obstruction. It can be used for removal of wax, which will help in easy removal without causing any much pain. The direction of jet when you're doing this syringing should be directed towards the posterior-superior canal wall. Never go straight towards the tympanic membrane. The direction should be towards the posterior-superior canal wall. So direction should be towards the posterior-superior canal wall. Never do syringing if there is a perforation in the tympanic membrane, or there is a hygroscopic or a organic foreign body, or there is otomycosis. Then you will not do syringing. Also in patients who have history of vasovagal attack, because this can stimulate the vagus and cause syncopal reaction. So all these are contraindications of not doing a syringing. And this syringing, is it used only for removal of foreign body, removal of wax? No, it is also used to perform a caloric test. Like how we saw the Siegel's pneumatic speculum is used for performing fistula test, Simpson's oral syringe is also used to perform caloric tests. So in caloric, we won't use body temperature water, we will use warm and cold water to see if there is nystagmus, telling you the integrity of the vestibular pathway. So this instrument that you see is your Simpson's oral syringe. The next instrument that we have is called as the Politzer's myringotome. So the name itself is giving you the answer. Myrings means tympanic membrane, tome means opening. So if you make an opening in the tympanic membrane, we call it as myringotomy. And now to make an opening or hole in the tympanic membrane, we require an instrument. So that instrument that is used to make an opening in the tympanic membrane, we call it as a myringotome. So where do we do myringotomy? We do it in ASOM with specific indications, like if there is no resolution of disease despite antibiotics, patient is presenting to you with excruciating ear pain with bulging drum, incomplete resolution, persistent effusion beyond 12 weeks, or there is a facial palsy, then we are doing in a patient with ASOM. In SOM, we do if there is failure of resolution for 3 months, you have waited and watched and it has not resolved, then you are going to do in patients with SOM beyond 3 months as well. So that instrument where you make an opening in the tympanic membrane, we call it as a myringotome. Now in patients with serous otitis media, we not just do a myringotomy, but we keep a ventilating tube between the middle ear and the external auditory canal. This ventilating tube that is present between the middle ear and the external auditory canal, we call it as a grome. So what is grome? Grome essentially means a ventilating tube. So the ventilating tube that we have between the external auditory canal and the middle ear, we call this as a grome. Then we have, for performing mastoid surgeries, we have certain retractors. Again, this is a common question. Retractors are some of the PYQs that you should know. So Mollison's self-retaining hemostatic mastoid retractor is a retractor that is in the name explaining you everything. So what is it? It is self-retaining, meaning once you open the retractor, somebody else does not have to hold it. It's a self-retaining retractor. Hemostatic, meaning it is going to stop bleeding, because when it is retracting, it is compressing the tissues, whatever it is retracting, so there will be no bleeding. So it is a hemostatic, used in which surgeries? In mastoid surgery. Now in mastoid retractors, there are various types and there is always a scope for confusion. So how do we understand what is what type of retractor? So if you see each arm of the retractor, if it has same number of prongs, like this has 4 by 4 or 3 by 3, equal number of prongs, then it is Mollison. So in Mollison, what do we see? Equal number of prongs, then it is mollicence. If you have unequal number of prongs like 4 by 3 or 3 by 2, which is unequal, then what do we call? Then we call that retractor as Wheat-Lanner's retractor. So Wheat-Lanner's retractor is when there are not equal prongs but there are unequal prongs, then we call it as Wheat-Lanner's retractor. Now you see here there is a retractor where you have got 4 prongs on one side, 3 prongs on another side. But why have I not labeled it as Wheat-Lanner? I have labeled it as Plester. Why have we labeled this as Plester? Because if you see here clearly, one prong is longer than the rest of the other prongs. So one prong is longer. So when you have one prong longer, remember PL, plester. So plesters will have one prong longer. So equal number of prongs, Mollison. MU reverse and make it W, Wheat-Lanners. Are they equal or unequal? Unequal. So 4 on one side, 3 on another side, we call it as Wheat-Lanners. Unequal but one prong longer. What do we call it as? Plester. So this is your Plester's retractor. Now if you see this retractor, I have just described there are 4 prongs on one side, 3 prongs on another side. So unequal number of prongs is going to be your Wheat-Lanner's retractor. Now all the retractors that we saw so far had rings to place your fingers to open and close. So we had rings where we could put our fingers to open and close the retractor. But if you see this retractor, we don't have a ring, we have a knob. So when you have a knob attachment for opening and closing the retractor, we call this retractor as a Jansen's retractor. Here our focus is not on the prongs. They are equal, 3 into 3. You may think it is Mollison, but why is it not Mollison? Because it does not have a ring, but it has a knob for opening and closing. Then we call it as a Jansen's retractor. Then let us look at another retractor. Here we are having a retractor which is having only single prong on one side, 3 prongs on another side. So single prong on one side, 3 prongs on another side. What do we call such a retractor as? This we call it as Perkin's retractor. So this retractor is called as Perkin, where we have got single prongs on one side, 3 or more prongs on another side. We call it as a Perkin's retractor. So single prong on one side, 3 or more prongs on the another side. We call it as Perkin's retractor. So Mollison's, same number of prongs. Wheat-Lanner's, unequal number of prongs. One prong longer, Plester's. Only one prong, Perkin's. No ring but a knob, Jansen's. So these are the common type of mastoid retractors that we use for performing a mastoidectomy. Then we have a nasal speculum that you see here that we use commonly or routinely for all ENT examination of a performing anterior rhinoscopy. This instrument is called as Thudicum's nasal speculum. It is used for performing anterior rhinoscopy. So the name of this instrument which is used for performing anterior rhinoscopy is called as Thudicum's nasal speculum. So we use the speculum to open the nasal vestibule so that you're going to visualize the nasal cavity proper with the help of this speculum. Then we have a self-retaining speculum. So if you see there are screws, once you open the speculum and you screw it, nobody has to hold it. So it's a self-retaining speculum. So this is called as Killian's nasal speculum, which can be a short-bladed one or a long-bladed one. It is used for again performing anterior rhinoscopy. It is also used for performing surgeries like septoplasty and turbinoplasty. So for all nasal surgeries, you can use this. It is used for anterior rhinoscopy as well. What is the advantage? Your hand will be free. So once you open it and fix it with the screw, your hands will be free, unlike Thudicum's where your one hand is involved in holding the speculum. So this is your Killian's nasal speculum. Now when you want to visualize the nasopharynx, when you want to do a posterior rhinoscopy, so for anterior rhinoscopy we used Killian's or we used Thudicum's. But if you want to do a posterior rhinoscopy, we use this mirror which is called as St. Clair Thompson posterior rhinoscopic mirror. The name itself is telling you it's used for posterior rhinoscopy. So it's called as St. Clair Thompson posterior rhinoscopic mirror. How do we differentiate this from an ideal mirror or an indirect laryngoscopic mirror? You see this has a bend. So a mirror which has a bend is your St. Clair Thompson posterior rhinoscopic mirror. Now while performing posterior rhinoscopy, you will insert this mirror mirror behind the uvula and put a tongue depressor. So typically the area of interest is going to be your nasopharynx. So the mirror is introduced behind the uvula and the tongue is depressed with the help of a tongue depressor, so that you have a good visualization of the structures from the outside. So a tongue depressor and a mirror is used for performing posterior rhinoscopy. What we are able to see typically is the posterior end of the nose and the nasopharynx. The structures are visualized in the mirror. So posterior end of the nose and nasopharynx are visualized in the mirror. Then when we come to fractures of the nose, we have two types of forceps. One is for the nasal bone and one is for the septum. So the instrument that we use for reducing the nasal bone fractures, we call it as the Walsham's forceps. So Walsham's forceps is used for nasal bone fractures. So whenever there is a fracture of the nasal bone, so for reducing the nasal bone fractures, we use the Walsham's forceps. So if you see, it has a rubber tubing on one side. Why do we have rubber tubing? On the other side, we don't have. So the end which does not have rubber tubing, say these are the two ends, one end does not have rubber tubing, the other end has rubber tubing. So the one that does not have rubber tubing will go inside the nose, the other one will go on the outside of the nose, and this has a rubber tubing because it should not cause any orbital complication or it should not cause any orbital injury. Once the prongs have gone and held the nasal bone, it is reduced to align the nasal bone into position. So this is used for reduction of which bone? For fractures of the nasal bone. Now for septal fractures, now whenever there is a septum in the midline, you want to reduce the fracture. So for septal fractures, you use this instrument which is called as the Ashe's septal forceps. So this is used for septal fractures. So for reducing the septal fracture, you're going to use this instrument which is called as the Ashe's septal forceps. This will help in aligning the septum straight. It is like your chimta or whatever we hold the instrument, right? Hot instruments in our hot boiling water or a pot of water in the kitchen, we hold it with a chimta, right? So it's like that. So it holds the septum from both the sides and you can reduce the fracture. It doesn't have a rubber tubing. That's the difference between the Ashe's septal forceps and the Walsham's forceps. Second thing is there is an angulation in Ashe's forceps, whereas it is straight in a Walsham's forceps. So this is how you differentiate. Walsham's forceps is for nasal bone and Ashe's forceps is for the septum. Then we have got a commonly used instrument for tonsillectomy, which is called as the Boyle-Davis mouth gag. So typically you want the mouth to be open and you want the mouth to be fixed, because when you are operating, you don't want the field to keep moving or to interrupt your surgery. So we use this instrument which is called as the Boyle-Davis mouth gag. It can have different types of tongue blade. You can have a Russell-Davis tongue blade, you can have a Doty's tongue blade, you can have different types of tongue blade, but basically it is a Boyle mouth gag with a Davis tongue blade, and they are assembled together. They are not present as individually. They are individually two separate instruments which are fixed together. So if you see, this part of the assembly is used to retract the upper jaw, whereas the tongue depressor is used for retracting the lower jaw. So it will open the mouth and it will help you visualize the nasopharynx. So when you have opened the mouth with this Boyle-Davis mouth gag, you have to stabilize it as well. So to stabilize this, we are going to use a bipod stand. So this is called as the Draffin's bipod, which is fixed to the mouth gag. So once you have opened the mouth, it is fixed with the help or anchored on these rings, which is called as the Draffin's bipod. Now this bipod has to be stabilized below by a plate, right? So that plate that is used to stabilize the bipod, we call this as the McGorran's plate. So on the McGorran's plate, you will have the bipod, and through this bipod you will have the mouth opening like so. The tongue depressor will open the tongue down and the mouth gag will open the upper hinge of the mouth gag will open the upper jaw. So this is how we open the mouth and fix the mouth whenever we are doing a tonsillectomy. The name of the instrument is called as the Boyle-Davis mouth gag. This instrument that is present is called as the Draffin's bipod, and this plate is called as the McGorran's plate. So these are the instruments that we use for doing a tonsillectomy. So Draffin's bipod I have told you, which is used for stabilizing the mouth gag over the Magoran's plate. Now to perform an adenoidectomy, now we do it under visualization where we have endoscope, we are able to see the nasopharynx, we are able to clear the adenoid tissue with the help of vision. But in olden days when they didn't have endoscope, they would use this instrument which is called as the St. Clair Thompson adenoidectomy curette. It comes with a cage or without a cage. There are two types, but we use commonly the one with cage initially. So what is this instrument? This instrument is used for removing the adenoid. So it is held like a dagger and it is inserted from the mouth into the nasopharynx, and then in the midline you keep curetting the adenoid mass. Now when those big chunks of adenoids are removed, you don't want it to get aspirated and you want it to come out, so you're going to use this with a cage. So in the initial part, when you have large chunks of adenoids coming out on curetting, to prevent that adenoid tissue to fall off or to get aspirated, you're going to use the one with cage. Later on, when most of the adenoid tissues have been removed and there is only remnant you want to curette, you can use without cage as well. So the name of this instrument for adenoidectomy is called as St. Clair Thompson adenoidectomy curette with cage or without cage. Now when we do a tonsillectomy, first you perform an adenoidectomy, then we are going to do a tonsillectomy. So when we are doing a tonsillectomy, you will hold the tonsil at the upper pole and start dissecting it from the bed. Now when you are dissecting the tonsillar tissue from the bed of the tonsil, you require a tonsillar dissector, and the name of this dissector is Mollison's tonsillar dissector. On the same dissector you have a retractor also. So if you see, this end is blunted and it is used for dissecting the tonsil from its bed. The other end is like a curve. So this will help in retracting the anterior pillar and see the tonsillar fossa if there is any bleeding point. So this end is called as your anterior pillar retractor. So we have anterior pillar retractor retracting the anterior pillar, and this is your blunt end. This blunt end is used for tonsillar dissection. So this is going to be using for tonsillar dissection, where you dissect the tonsil from the bed. And what are you using this anterior pillar retractor for? To retract the anterior pillar so that you can see the bed if there are any bleeding points. So the name of this instrument, Mollison's tonsillar dissector and anterior pillar retractor. Now, once you have dissected the tonsil of the bed and you see that the tonsil is hanging from the bed by a pedicle, you have to crush the pedicle. So, to crush the pedicle, you will use this snare. So, this snare is having a metal thin wire that has been connected to this snare end, and when you take the pedicle inside this snare, you are going to pull it so that the base will get crushed. So you're going to retract this end of the snare so that the base will get crushed and you're able to cut off the tonsil from its bed and dissecting out. So the name of this instrument for dissecting or cutting off the lower pole of the tonsil from the bed, we call it as Eve's tonsillar snare. Then we have a tongue depressor, commonly again used in ENT for visualizing the oral cavity, for examination of mouth and lips, for visualizing the tonsils, for visualizing the oropharynx, for performing even cold spatula test, where you keep the tongue depressor in front of the nose and ask the patient to breathe out. Or if you see equal misting on the tongue depressor, it means that both the nasal cavities are having good airway. If you see more misting on one side, less on another side, it will tell you that there is an obstruction on the other side. So it's used for also performing a cold spatula test. So it's used for many purposes, commonly for examination of the oral cavity, for the oropharynx, also used for performing cold spatula test. So the name of this instrument is called as a lax tongue depressor. So this is your lax tongue depressor. Then this instrument used for visualizing the larynx is called as the indirect laryngoscopic mirror. So in a posterior rhinoscopic mirror, you saw there was a bend, but here there is no bend, it is straight. So this mirror which is straight is your indirect laryngoscopic mirror. So in this mirror, we are trying to visualize, the aim is to visualize the larynx. So we will pull the tongue out, and once you pull the tongue out, the mirror is placed behind the uvula facing downwards. In posterior rhinoscopy, you face it upwards. Here you are facing it downwards. Now, since the tongue is pulled out, you get a nice unobstructed view of the larynx. So, you will be able to visualize the larynx completely in the mirror. So, this instrument where we are trying to visualize the larynx, we call it as indirect laryngoscopic examination. So, here we use only the mirror. We are not using a tongue depressor. We are instead pulling the tongue out. In a posterior rhinoscopy, we were using a mirror and we were using a tongue depressor. In posterior rhinoscopy, the mirror was facing upwards. In indirect laryngoscopy, the mirror will be facing downwards. So that is about your indirect laryngoscopic mirror. Now, to visualize directly, you can use an endoscope or you can use a laryngoscope. So this end of the laryngoscope you will visualize, and this end is used to stabilize on the larynx. So directly you will insert it through the mouth and fix it on the vocal cord and see the larynx with the help of this laryngoscope, which is called as the direct laryngoscopic examination or rigid direct laryngoscope. You can also use a 70 degrees rigid endoscope to visualize the larynx. Now, for performing vocal cord surgery or laryngeal surgeries, for microlaryngeal surgeries, we use this instrument which is called as the clean saucer suspension laryngoscope. So, this end again is used to visualize the larynx, and above this end we fix our microscope. The other end will fix on the vocal cords. With the help of microscope, we are able to see the structures across the laryngoscope in a magnified way, and through this aperture only we pass our instruments for resection of the lesion. So this instrument, which is used for microlaryngeal surgery, is called as the clean saucer suspension laryngoscope. Then when we are talking about ENT surgeries, tracheostomy is one of the very important surgeries. So when we are doing tracheostomy, we use all common cold instrument from the starting to the end of surgery. But typically when we are making a hole in the tracheal rings, between the second and the third tracheal ring, when we make a hole, we want to dilate that ring so that the tube can pass easily inside. The tracheostomy tube can pass easily inside. So that instrument which is used to widen the tracheal ring, we call this as the Trocheus tracheal dilator. So when we want to dilate the opening made in the tracheal ring, we use this dilator which is called as the Trocheus tracheal dilator. Then we have this commonly used instrument in every ENT OPD where we have a bull's eye and a head mirror. Today we have got LED, head lamps. So we are not using most commonly these head mirrors. What we have is our headlights, where we have a headlight and head ring and a light attached to it in the midline, which will give us a very beautiful view and in fact more more brighter view. So we need to know that this instrument is called as a head mirror. This has a overall diameter of 9 mm and the central aperture is of 2 mm. So central aperture is 2, overall diameter is 9. So it gives us a focal length of 18 centimeters. So the patient is made to sit at a distance of 18 centimeter. This is worn by the examiner on the right eye, and with the help of mirror, with the reflective surface of the mirror, the light is focused on the area that the examiner is willing to visualize, like the nose, like the ear, like the mouth. The light source is kept on the patient's end. So if I am sitting here, I'll wear the mirror. The light source is kept behind the left shoulder of the patient, and from there the light will come, reflect on the mirror and go to the target structure that we want to visualize. So this is a bull's lamp which is kept behind the left shoulder of the patient, and this has a 100-watt bulb, and this will shine the light on the mirror, and with the help of the reflection coming from the mirror, we are able to see the target tissue. So this is your bull's eye lamp. So this covers your basic instruments which we use in OPD, what we use for tonsillectomy, what we use for adenoidectomy, what we use for MLS, what we use for mastoid. Basic examination related instruments is what I have discussed. For any other things or any other doubts, you can always reach out to me and I'm always there for helping you. Wishing you loads of love and good luck. Take care and bye-bye.